Hey folks, we're live for EMS Challenge here at Madison Fire. Thanks for hosting us. Super appreciate it. It's a great facility that you have, and some nice weather as well. So, start of the new year, we've got two new fellows, Dr. Ahmed Saaed, Dr. Jared Millard are going to be EMS fellows for the year. Today we got Dr. Saaed speaking, and then Dr. Pittman, one of our senior residents. But a lot of good things coming up. We'll be in Fultondale the second Wednesday of August, and then over in Tuscaloosa the fourth week in August. So I know for some of y'all, that'll be like going to the Holy Shrine, and some of y'all is like the Wailing Wall, right? But we'll be in Tuscaloosa here pretty soon as well. So cool. Thanks for having us, and we'll get started with Dr. Saaed.
All right. Can we hear me? We good? All right. So we're going to talk about asthma and COPD. It's a very important topic. A lot of people have asthma and COPD, and managing it is tricky. You would think it's straightforward, but it can get very tricky. We're going to start off with our disclosure statement. We have no relevant financial relationships to disclose. The reason we started the EMS challenge was to continue our education, make sure we're taking care of the state of Alabama's patient population to the best of our abilities, and stay on top of our game. The learning objectives for today, we plan on reviewing respiratory anatomy, review the difference between COPD and asthma, and then we'll end it in the towards the end with some case presentations where we'll talk through what the patient will look like and what our next steps will be and how we will manage this patient in the field and in the hospital. So let's start off with anatomy, right? So the airway is split up into two parts. You have your upper airway and your lower airway. So your upper airway consists of your sinus, your oral cavity, your oropharynx, your nasopharynx, and your laryngopharynx, right? When air goes through it, it's the conduction system. So when your air goes through your oropharynx, your turbinates, it starts having some turbulent flow. You have your mucous membranes and blood vessels there that cause it to catch any kind of particles that you have. So that's how you get your boogies, get your particles, and it starts warming and humidifying the air so that when it goes down to your lower airway, it's warm and humidified. After your glottic opening is where you will start your lower airway structures. Your lower airway structures consist of your trachea, your bronchi, main stem bronchus, and bronchioles, your lungs, and your alveoli. Right there. So let's go through the diaphragm of the human lung, right? So when we go down, looking at right there, yeah. So when we go down towards our lungs, you got your trachea right in the middle. The reason we have cricoid cartilage around our trachea is because we're negative pressure breathers. And during the respiratory system, we go through a lot of different pressure changes. So think about it. No problem. All right. So where were we? Not the boogies. Yes, cricoid cartilage. So your airway system goes through a lot of different pressure changes. So think about it as a straw. When you suck on a straw, you say you cover the tip, the straw will collapse, right? So if you don't have these cricoid cartilages in your trachea that keeps your trachea keep your lungs open, your tubes open, then it would just collapse. So that's why we have those cricoid cartilages. Then we go down to our main bronchus stems. Your right side, as you can see, the main bronchus stem is a little wider and a little more vertical. So most of the time, our foreign objects, or when we say push our ET tube too far, right main stem, your tube. On the right side, you have three lobes of your lung. You got your upper, middle, and lower lobes. On the left side, you have just your upper and lower lobe. The reason for that is you have your cardiac notch right there on the side where our heart sits. And then from your main bronchi, you go to your bronchioles. And from the bronchioles, you have your alveoli. This is where gas exchange happens. So in gas exchange, it's basically respiratory system has three steps, right? You have your ventilation, your diffusion, and your perfusion, right? In the ventilation system, part of the respiratory system, you have air coming into and out of the lungs. In your diffusion system, you have the movement of oxygen, as you can see, coming down to the alveoli. Your oxygen exchange happens, and your carbon dioxide exchange happens moving out of the bloodstream. And then the perfusion part is your pulmonary veins and pulmonary arteries, and your circulatory system in the capillaries are exchanging nutrients, which are important for our breathing system. So this is just a broad overview showing you the capillary bed of our lungs. This is where the perfusion is happening. And always remember, right? Pulmonary vein and pulmonary artery are different from what you just normally would think of oxygenated and non-oxygenated blood. Your pulmonary artery is actually the non-oxygenated blood that takes blood to your pulmonary system, and your pulmonary artery is the oxygenated blood that would do the exchange of your capillary. So they are oxygen rich, carbon dioxide poor, while your pulmonary artery is carbon dioxide rich and oxygen poor. Any questions so far? All right. So let's talk about our respiratory drive. Our respiratory drive is basically gas exchange taking between the lungs, is all controlled by a central nervous system. So whenever a kid, say, is acting bad and they hold their breath, right, they can pass out, but their nervous system is going to kick in and they will start breathing again on their own. We do have some voluntary control of our breathing, but we're going to breathe regardless, whether we think about it or not. It can be suppressed though, right? Opioid overdoses, when we give patients sedatives, or any kind of brainstem injury. So that will suppress your involuntary respiratory drive. We have central and peripheral chemoreceptors that sense our arterial carbon dioxide and oxygen, right? So if you are retaining, if you're hypercarbic, your body automatically is going to start wanting to breathe faster. So it will adjust according to the levels that your sensors are picking up. So let's go getting a good overview of what anatomy and physiology of our respiratory system is important, because now when we talk about COPD and asthma, we have an idea of what is normal and what's abnormal and how do we treat it. So COPD, right, basically is an obstruction during expiration phase of your airway. So it could be because of secondary to secretions, edema, bronchospasm, bronchoconstrictions. What's happening is your lungs elasticity, also known as compliance, is not as strong as it was when you were younger. So when you breathe out or breathe in, your intercostal muscles and your lungs stretch in and try to get as much air as we can. But when you relax, they stretch out. Now, the obstruction leads to increased airway resistance and air trapping. This causes you to have your VQ mismatch that could cause you to have hypoxemia and hypercarbia, right? This is also why you will have a increased time on your work of breathing, leading to fatigue and ventilatory failure, all right? Biggest risk factor, COPD, usually younger folks do not have it. Biggest risk factor is smoke, environmental exposures. So if somebody's been smoking like for 40 years, 20 years, it causes chronic damage to your lungs. For us in the fire field, respiratory infections, occupational hazards, and chemical exposures can also cause it. So that's why we always have to be on top of our gear and make sure we're taking it seriously when we go into situations. And then also is you got the genetic risk factors of alpha-1 antitrypsin deficiency. You had a question, sir? Well, like, no, it's not necessarily quite old enough. Like we are seeing it, just we can't rule down the initial cause because we don't know what all they've been exposed to. Like unless we want to do a study and follow like a cohort of kids that are vaping. I don't know how we'll get IRB approved, but like following a cohort and then seeing what happens with them. But the risk factors are the same, so they will have these same kind of damage to the lungs, where the elasticity of the lungs will scar over and cause you to have COPD-like symptoms. So, I mean, it's the smoke, right? It's the chemical exposure that's happening. So, I don't think we've had actually specific studies, but if you were to make an educated guess, it's not going to probably not yet.
There has been some research published about the vaping, but it tends to lead to something that's commonly referred to as popcorn lung.
Popcorn lung. That's
Yeah,
different though.
but not
Yeah.
necessarily the traditional emphysema and chronic bronchitis that we kind of traditionally in medicine have defined as COPD.
Yeah.
So the difference is the other products of combustion from tobacco aren't present, and that tends to lead people to believe that it's a safe alternative. But I would guess that it is probably just dangerous in other ways.
Yeah, it's just like the new trend right now, everybody's doing hookah, right? Thinking that it's a cleaner smoke tobacco, but smoke is smoke, right? You're still causing your lungs to be exposed to irritant. All right. So we were kind of basically getting to the point. So with COPD, you will have your chronic bronchitis, folks, that have the inflammation of the lining of the bronchioles. So these are the people that have a productive cough with mucus. And then you also have the emphysema, folks, which is the alveolar destruction of the alveoli due to the exposures like smoke, tobacco smoke, irritating gases. So like vaping and all that we were talking about. In theory, it makes sense that this will happen. One or both could be in COPD, but most of the time one is more predominant. You either have bronchitis or emphysema. And looking at a picture of this, you can see a healthy lung on y'all guys' right side, and see how your alveoli, airway lumens, not as much mucus secretion is going on. Your bronchioles look very happy. While on the other side, the COPD side, you see the excessive mucus production. So this is happening because your ciliary muscles, your ciliary fibers with smoke basically get paralyzed and they can't move all of that stuff out. You get destruction of your bronchioles and alveoli. You get hyperexcretion of the mucus, and then you see your airway diameter, the lumen airway, right, on a healthy lung compared to a COPD lung. So this is where you will get your wheezing, cough, and everything like that. So in a COPD exacerbation, you have your shortness of breath, increase in sputum production. Another question you always want to ask, is there a different color in your sputum? What color is it? Is it rusty? Is it green? Is it yellow? That's an important question to ask your patients when you're out there. Now, as they start retaining carbon dioxide, they may have an altered mental status as well, which is very important because that's a sign like we're not going the right way. Something is going on. Your lung sounds initially can have wheezing. Now, what's the most concerning part is when you start having diminished lung sounds, that means that they are tiring out. And we need to act fast because they're not moving any air. There's a lot of air trapping. They're fatiguing. Their accessory muscles are fatiguing. We need to act fast. We need to make sure we're doing what we need to do our next steps, which we'll go over. So these patients will most likely be tachypnic, tachycardic, and are going to be using their accessory muscles. Okay, so kind of like if everybody would just indulge me, we'll do this exercise together, right? Let's take a deep breath in and out. In and out. Right? That's normal. That's how we breathe. But in COPD and asthma patients, take a deep breath in, out, in again, out, in again, out. Before y'all pass out, we're going to stop. So they're basically breath stacking on top of each other. They're not getting enough time to expire all of that CO2. And then when you start breathing fast, you're going to start panicking. As you panic, you're going to get tachycardic, right? As you go tachypnic, you go tachycardic, you're going to have these insensible losses in your sweating. You're going to start fatiguing, and you're going to start using your accessory muscles. So that's why we have to be very calm with these folks and try to talk them through what's happening. Because if you're not breathing, or if you think that you're not getting enough air, you are going to start panicking and think that you're about to die, right? So that's a scary moment. So how do we manage these patients? Right off, you put them on oxygen. Your goal is 88 to 92%, right? The theory of COPD is the hypoxic drive, where they actually rely on the oxygen levels at this point to kick in their drive. If you hyperoxygenate these folks, their their respiratory drive will actually die out, thinking that they're good. Okay. You want to go ahead and put this patient on a 12-lead EKG, cardiac monitor, and then the medications you want to use. You want to go ahead and start off with albuterol right off back, 5 milligrams, 1 to 2 puffs every 3 minutes as needed, right? Albuterol is a beta-2 agonist, so it causes you to have bronchodilation, inhibition of the histamine release, and one thing to be wary of, this is something that we forget a lot, is that it shifts potassium into our cells. So when we are giving these patients albuterol, this is something to keep in the back of your mind, because I'll bring this back up at the end of our presentation of how this is relevant. Okay. Albuterol is also a beta-1 agonist, so that's why when people get albuterol, they become tachycardic, right? The second drug that you should give them is Atrovent. So this is your ipratropium. Most likely, you want to do the dual-nep, which is the best thing to do, because ipratropium is longer lasting and it will stay in their system a little longer to help with the bronchodilation. 0.5 milligram nebulized. If you're doing a dual-nep, if you have a dual-nep, 3 mg per 0.5 milligram. All right. For ipratropium or dual-nep, 3 doses, you've hit max benefit. Going over 3 doses, you're not really getting much more benefit after that. And then steroids. I think all of us should be carrying steroids. I believe we do carry steroids. Most of us carry steroids. 125 milligram IV, just go ahead and give it to them. It's going to start taking effect on the anti-inflammation part of the COPD exacerbation. Not going to be immediate, but it will start helping them overall. All right. One of the risk factors for COPD is a pneumothorax, right? How do we know if patients having a pneumothorax? You will have altered metastasis, bradycardia, or tachycardia, hypotension. What is the easiest way we can figure out a patient has a pneumothorax? There you go. Easiest way there is, right? Look at the patient, touch your patients, hear your patients. If they have diminished breath sounds on one side and not the other side, most likely they have a tension physiology going on. What is happening is now you're basically causing a compartment-like syndrome in the lungs. So basically putting the pressure down, we're not getting enough venous return into the heart, we're not getting enough cardiac output. So basically tamping down on the heart to do anything, and then leads to altered metastasis and cardiac arrest. What do we do with attention pneumothorax physiology? What is the treatment? Needle decompression. What is the landmarks we're using? There you go. Secondary costal, midclavicular, or 4th and 5th mid-axillary. You have your triangle of safety, right? But you got to be careful, right? Make sure you don't go too low, because if you go too low on your right side, what is an object you can hit? Liver. What if you go too low on your left side? Spleen. Are these two very bloody things that take care of your body? Can you hemorrhage out? All right. So we got to be careful. It's a situation where your adrenaline is pumping, but take a deep breath, think things through, right? We're only going to help the patient and not cause more damage, and you just approach that. In COPD, usually pneumothoraxes happen from bleb ruptures. Patients can have these small blebs spontaneously in COPD that pop up, as you can see on the picture on the top. And if you put these patients on CPAP and BiPAP, which sometimes you should, if you get attention physiology, should we keep them on the CPAP BiPAP? No, because what's going on? Right, positive pressure, right? We're putting them on positive pressure ventilation to help with the work of breathing, but now we've caused attention physiology. We decompress the chest, take them off the BiPAP, all right? And then continue with your management as per protocol and bring them to the hospital. Any questions so far on COPD management? All right, let's talk about asthma. So these patients could be kids to adults, to elderly folks. Asthma is a sleeping dangerous disease that we do not think could, when they go into asthma exacerbation, how sick these patients are. And our typical treatments aren't what we want to do with these patients. These patients can die on you quick. So that's why we have to act quick when these patients are in distress. All right. In asthma physiology, you basically have a reduced airway diameter causing smooth muscle contraction, vascular congestion, you're getting bronchial wall edema, and you get thick secretions, right? Asthma can happen randomly, something that triggers it. While COPD is mostly these people live like that. They're always chronic. Asthma is a trigger, causing the increase in work of breathing, causing the diameter to get more inflamed, and your bronchioles being more hyperresponsive, right? So these patients might be doing well for a couple of days, and all of a sudden just have an asthma attack out of nowhere. Viral upper respiratory infections, environmental triggers like pollen. That's why when you have a asthmatic, you don't want to smoke around them. Secondhand smoke can cause this. Mold, animals, dust mite, and the thing that survived everything, cockroaches. Cockroaches could do it too. Medications, industrial chemicals. Sometimes asthma can be induced by exercise, so they have to be careful with that as well. Emotional stress. So in asthma, you have your normal lung on y'all's right side and the asthmatic lung on the left side. As you see, the lining around the bronchiole and the bronchi is nice, not too thick. You see, you have a good airway diameter, normal amount of mucus. It's not, muscles are relaxed, not so tight. Now look at the asthmatic lung. See how those are basically constricting down, strictures. Your lining is swollen, inflamed, excess mucus. This is where the wheezing comes in from. This is where they're wheezing. They're working harder to get through the airway. So your airway resistance is going up. So in asthma exacerbation, you get shorter breath, wheezing, tachypnic, accessory muscle use, tripod positioning. Now, this part, right, we were talking about, your lung sounds outside of wheezing can be diminished. When the lung sounds are diminished on both sides, that means their accessory muscles are tiring out. This patient is fatiguing, and they are not moving any air at all. This is called the quiet chest. This patient will become altered. They're going to become hypercarbic. They're going to have hypertension most of the time, hypoxia, severe exacerbation. Biggest risk factors when you go see a patient with asthma exacerbation, when you got to ask, not necessarily the patient because they're already dealing with something, but family members. Has this patient has a history of multiple intubations? Have they had a recent ER visit with asthma exacerbation? Are they using their inhaler like almost every day, multiple times a day, multiple times in an hour, and did they do any drugs? You got to be non-judgmental about that part because a lot of people will not tell you if they did. Like, look, man, I'm not the police. I'm here to take care of you. I need to know, did you do any drugs that could cause this exacerbation to happen? Because I might be able to reverse that if I have the drugs. Or if not, we need to let the physicians know when we get to the hospital because this is a dangerous disease that could cause them to die on you. Management of asthma exacerbation, very similar to COPD management. You get supplemental oxygen, back valve mask, and then your non-invasive airways, your CPAP and BiPAP. Albuterol for asthma management, 5 milligrams nebulized every 3 minutes. Atrovent, 0.5, or Duoneps every, say, 3 minutes, but no more than 3 doses. Doesn't really do much after that. 125 milligrams of methylprednisolone IV. In adults, your second line after your inhalers is to give this patient magnesium, 2 grams diluted in 250 250 mils of normal saline, goes over 20 to 30 minutes in IV IO, right? What magnesium is doing, it causes relaxation of your bronchial smooth muscles, and it is the preferred second line in adults for severe exacerbation. Also, with this, you got to be careful for them becoming hypotensive. So go ahead and hang some fluids as well when you're going to give this magnesium to these patients. oldie but goodie. Before albuterol was around, before all of these other drugs, the treatment for asthma exacerbation was IM epi. That was the original treatment for asthma exacerbation. 1 to 1,000, 0.01 mg per kg, up to 0.3 mgs for IM. Got to be careful with people with heart disease, elderly patients, and you want to avoid this in the first trimester of pregnancy, because it could have some tetragenic effects. Okay. Now.
Hey, Doc.
Yes.
Sorry. So we got a question online. I think there's a little bit of confusion I've noticed that's pretty generalized in the EMS about duoneb and role of ipratropium. So the specific question we got today is, when would albuterol be more appropriate versus a duoneb? And is this a progression? I think what they mean is, should you always start without the ipratropium and progress to it, or?
I said go to albuterol every time. That's no problem with that. But duoneb has the albuterol in it. Ipratropium is just assisting for longer effects. So albuterol always. If you don't have ipratropium, that's fine. Albuterol always. But if you have the duoneb, why not give the patient the benefit of both drugs at the same time? It's not a progression. It's more like, if you have a duoneb, start them on a duoneb. It's just doing the same thing.
Yeah, there's no risk to it. So if you're carrying a duoneb and your patient needs 3, great. They need 3 more, great. The ipratropium part is not going to work anymore, but it's not going to hurt them. So it just depends on what you have.
Exactly.
You can give people albuterol until they get so tacky, you have problems, or a K gets down. So you're not going to really hurt anybody. And same thing with the ipratropium. It's just after you give 3 doses of the ipratropium Atrovent, you really kind of maxed out the receptors. It doesn't do any good. So
yeah, exactly. It just, at that point, you're just basically causing a placebo effect for the patient. Maybe they might feel better just because they're getting some sort of drug.
Yeah, so I say buy whichever's cheaper, but the duoneb's probably the better choice, better bang for your buck.
Because it has 2 different mechanisms of actions, and it's something's longer lasting and short acting on top. So it just helps the patient if you want to look at their trajectory long term. So what's the difference between this epinephrine versus cardiac dose epinephrine? What is the ratio for a cardiac dose? 1 to 10,000, right? So be careful about this when you're doing these IM epis, right? Like, we're not gonna just pull up code epi and just give that to the patient, right? We need to dilute this. Now, this is where you guys probably will get scared, right? Pediatric asthma management. This is where you need to know your dosages, right? For albuterol, you want to do 0.1 to 0.3 mg per kg, max 5 milligrams every 30 minutes for a pediatric. No more than 5 milligrams. Magnesium sulfate, 40 mg per kg IV over 20 to 30 minutes, max 2 grams in pediatric patients. Like I said, you got to watch for hypotension when you're giving magnesium. You want to consider a fluid bolus 10 to 20 mils per kg on a pediatric patient. Steroids, 2 mg per kg IV load, max 60 milligrams. No more than that. All right. Epinephrine, the 1 to 1,000, 0.001 mg per kg, 0.3 mgs IM. Epinephrine is the preferred second-line agent for pediatric patients in severe asthma exacerbation. What is the second-line agent for adults? Magnesium. Okay? These patients, you want to give them CPAP as well. Now, that's why are we putting a patient that's on asthma exacerbation with already air trapping, negative pressure, positive pressure now? Why are we doing that? Isn't that going to make the asthma worse? True, it can, but what CPAP is doing is helping the patient with their work of breathing, right? It's allowing the patient to have limited use of their accessory muscles, so it will help them not have to work as hard and helps them calm down. You want to titrate up to 15 centimeters, and then always remember the contraindications for non-invasive positive pressure ventilation, right? So what is the absolute one? We need to intubate this patient, cardiac arrest, unstable cardiac arrhythmia. Relative contraindications, this patient recently had facial surgery, their GCS is less than 10, they're having severe upper GI bleeding, they have a significant airway obstruction, and just had some sort of procedure on their gastric anastomosis, or you do not have enough people to help you manage non-invasive pressure ventilation. You um, you got to be careful with that, right? You want to put somebody that's bleeding out their mouth, mask on them. A person that's just puking everywhere, you don't want to put a mask on them. A person that cannot answer your questions appropriately, you don't want to put a mask on them and then make things worse. So, use your best judgment on these patients. Most ambulances will have a CPAP. Now, some of our critical care providers are going to have a BiPAP. So the way BiPAP works is it delivers positive pressure in variation, right? You have your inspiratory pressure. Usually, it can go from 8 to 20, but you usually start at 8 to 10, and then you have your expiratory pressure 3 to 15. You start 3 to 5. So that's when you hear like it's 10 over 5, 8 over 5. So that's your inspiratory over expiratory. This does require a ventilator, so that's why most of the time it's usually the critical care folks that have the ventilator with them. Helps with reducing the work of breathing, and has been shown to lower intubation rates in COPD patients and asthma patients. All right, similar contraindication, right? The mechanism of the machine is different, but similar contraindication for non-invasive positive pressure. All right, next question that I have for you guys: when should you intubate an asthma patient? So, I was always taught in residency, you never intubate an asthma patient unless you have to, right? Because intubating an asthma patient is really close to basically just go ahead, sign their death certificate. You're not going to be able to keep up with what's going on with them. So cardiac arrest, obtunded, you cannot clear the airway, and respiratory arrest is impending, right? You want to reference basically similar contraindications to your non-invasive positive pressure. Kind of use your best judgment. This patient needs to be intubated. Do we have the similar ventilator settings that we have for normal folks, but as soon as you put them on? Do we just put them on just any kind of ventilator settings for an asthmatic patient? Why not? They're trap air, right? And then what's happening when they're trapping air? Barotrauma. They call it compartment syndrome. It's going to lead towards what? Cardiac arrest, right? So what you want to do is you want to use your volume control settings on your ventilator. You want to put the patient breathing 10 breaths per minute is where I would start. It's low, but you want to start at 10 breaths per minute because we're giving more time to expire. You want to go ahead and put their flow rate at high at 80 liters per minute. Where would you want your PEEP to be at? Low. Because what's happening when they already have that air trapping in there? So they're already auto peeping, right? So you want to start your PEEP maybe at 3 and work your way down if you need to. Okay. And then what's your volume? What do we normally start at volume for ideal body weight? Yeah, but like what is that? 7, 8, 5. Oh, that's just me over there. So I'll start with like 7 pounds per kg for the body weight for the ventilatory volume control. You want to make sure you maintain their oxygenation at PO2 of 60. You want to make sure their oxygenation stays somewhere between 88 to 92, and you have to keep an eye on their plateau pressures. Right, their plateau pressures is important because this is where we're risking tension pneumothorax and worsening barotrauma physiology. Now, remember when we did that exercise earlier of breathing in and breathing out, and breathing in quickly and breathing out? So over here is our flow chart. Everything above that line is inspiration. Everything below the line is expiration. In normal breathing, you see where the arrows are? That should come up to your middle line right there. That's normal breathing. This right here is showing air stacking. So when you get your ventilator set and you're seeing this, that means you're breast stacking the patient. So you want to adjust your ventilator setting to where they're coming all the way up. This is where your inspiratory and expiratory ratio can increase from 1 to 3. Especially one thing I forgot to say is as soon as you intubate this person, when you're bagging, you will have some resistance. Fight the urge to just hammer the back all the way through, right? Just calm, easy bagging. Make sure you're doing every 6 seconds, because what would happen if we just hyperventilate them and just give them all of the air inside? We're basically making it worse, right? And also, when we're intubating these patients right here, you want to make sure you got your most experienced provider intubating this person. This is not the time when we're giving our new medic, new nurse, new doctor first pass. These patients, when we're intubating, you want to get them. You got to take the ego out of this, right? Because our new people need to learn this is not the patient you teach them on, because you want first pass success every time. Because the longer you wait, the more we're causing air trapping inside of this patient, causing hypercarbia, causing our acidosis to get worse. Okay. The tube that we want to use for the patients like this is basically bigger the better, right? If we use a 7.5 on a woman, try 8. 8.0 on a man. If you have an 8.5, try 8.5. Because the bigger it's gonna. What happens when you have a bigger diameter with the airflow? Well, volume, less resistance, right? Because all is happening is you have increased resistance. You have less resistance now in patients like this, so it's going to help. And if you want to do your ICU colleagues a favor, most of the time these patients are going to go up, they're going to need a bronchoscopy for all the mucus plugs that they possibly have. So with a bigger tube, they could easily go down, do a bronchoscopy, and help the patient out. Once you've intubated this patient, what do we need to think about next? Post-sedation meds, right? This is where we always forget. We get so excited and caught up in intubating the patient, inducing the patient. We got to put the patient. Now what do we do? Now we got the patient intubated, right? Normally you want the patient somewhat active, somewhat aware. Asthmatic patients, you put them down. You put them down hard, right? Use propofol or ketamine if you have it. I like propofol or ketamine because both cause bronchodilation. Make sure you put some analgesic on, fentanyl, morphine, whatever y'all carry. Make sure you treat their pain, because think about it, when you're going to sedate them so hard, make sure you treat their pain as well, right? Reason for sedating them is because it's just allowing us to take over their whole ventilatory system and allow us to control everything. So these patients need to be out, okay? Rarely, but sometimes, especially if our critical care transport folks that do helicopter, you might have to paralyze these folks as well, right? I would say if you have to, you do it, but just be careful, because now you've given them steroids, and paralytics with steroids could lead to some myopathies. Muscle myopathies could happen, but that's a long-term effect, not a short-term effect, okay? But if you have to, do it, because it's more about safety for you guys when you're flying. And then you will get, say if you're in the hospital, you'll get an RT to come up and might say something smart to you like, did you not see this carbon dioxide is all over the place, it's high, they're acidotic. In this patient, making sure the numbers look good is actually deadly to this patient. Permissive hypercarbia is fine. You don't treat the numbers, you treat the patient. Okay, a little acidosis. I'm not talking a pH of 6.9. All right, let's be sensible. But a little acidosis is okay, and permissive hypercarbia is okay in this patient. That's what we're keeping this patient alive. Okay. Now let's go through some case presentations. Everybody cool? Anybody got questions? Anything before we move over? All right. So our first case, you have a 26-year-old female you're dispatched to for respiratory distress. You get on scene. She's wheezing. Says that she's been using her home inhalers and her rescue inhaler has had no relief. You put her on the monitor, put her on 12 lead, your vital signs. She's tachycardic at a heart rate of 105. Her blood pressure is 128/72. Respiratory rate is 24. Her oxygen sat is 91% on room air. On physical exam, right, we got to touch our patients. You have bilateral wheezing on lung auscultation. This patient is tripod. What are we doing? What are our first steps? Okay, I heard it. Doing that. What else? Doing that. Sodium medrol. One more thing. It's adding 91%. Oxygen. Supplemental oxygen, Duanebs, steroids. We start them right away. Go ahead, get access, get this patient comfortable. Talk to them, right? Tell them like you're gonna be okay. I know it's a lot going on. We're gonna help you because they're already anxious. All right. So you place the patient on supplemental oxygen. You give them a Duaneb steroids. Now you start beginning transport. She got better initially, and now all of a sudden she started desatting. Wheezing got worse. You started having some diminished breath sounds bilaterally. What do we do next? Exactly. Yes. You push magnesium sulfate, 1 to 2 milligrams over 20 to 30 minutes. What is one thing we need to be worried about when we push mag? Hypotension. So what else should we do with this patient? Hang fluids. All right. What is something else we could do along with mag if this patient is not improving? She's still talking to us, just struggling a little bit. CPAP, put them on CPAP. Epi will not hurt either. Okay. Dr. Saaed, this patient's tachycardic, hypertensive. All of this is because of what's going on, right? If you give them IM epi to get some bronchodilation, their breathing helps, it gets better. Those numbers will get better too, right? So that's why we say like we don't treat the numbers, we treat the patient. Okay. So we gave this patient MAG, we gave him epi, we gave him CPAP, arrived, patient did well. Second patient that we have a 67-year-old male, got a call, worsening shortness of breath, has been having productive cough, sputing for the last 3 days. You arrive, patients, you put him on the monitor, tachycardic at 112, tachypneic at 25, blood pressure is 143 over 82, satting around 82% on room air. You look at the patient, they're tripoding, they're very anxious, they have diminished breath sounds bilaterally, and they're using all of their accessory muscles. Next step. What else? Not bad idea, but what is one thing we could give them right away? All right. So oxygen, Duanebs, and then what is one thing that will help with the inflammation? Steroids, right? Most I'm not sure if everybody has this, but most CPAP masks you can do inline albuterol with it. So why not do two things at the same time? Put them if you want to put them on CPAP, put them on CPAP. Do inline Duanebs, albuterol with it. Give them steroids. They're getting supplemental oxygen. Just you got to do the basics first before we move on to the next step. We're not going to just jump all the way, right? Because in an asthmatic or even a COPD patient, you want to try to get the control with the lower, least invasive procedures before you have to get to the point where you're like, oh man, we got no other option. Okay. So you gave the patient steroids, you gave them two Duanebs. Patient staying still oxygen saturation is still staying low. They're starting to become a little confused. At this point is when we want to transition them to CPAP and BiPAP. All right. And then will we continue doing Duanebs or not? We've only given them 2. Keep going. Yeah, keep going. Right. I will give them another Duaneb. When we're getting into this point where the patient is starting to become mildly confused, I put them on CPAP or BiPAP. This is where you want to like start getting your advanced airway ready. Just have everything ready. I'm not saying we're there, but preparation is always the best thing, right? Start having all your advanced airway stuff ready, because once we have to pull the trigger, we don't have much time. right?
Question. I know we talked about relative contraindications to CPAP, and we're like the last slide we're talking about worsening altered mental status, and I know you talked about that being contraindications to CPAP earlier. Can you go into a little more depth on that? Because I get questions on that a lot.
Ultimate status, right? GCS is less than 10 or something. This person is mildly confused. Biggest thing is, can they protect their airway? That's where I'm like, if I'm doing a CPAP, can they protect their airway? And are you alone if it's just you in the back of the truck and you can't keep an eye on the patient and they're getting a little more confused, maybe that's not the best choice. Because if you take your eye off and they're throwing up everywhere, it's in the mask, we're causing an aspiration risk. But if they can answer your question somewhat, they can keep their airway open, try it, because it's going to help them. And always have somebody keeping an eye on them, right? I'm not saying like just sit there and focus, look at them, but like you can do stuff, but just make sure you're aware of the patient and their condition, if it's deteriorating or not, or if it's getting better or not. So we put the patient on CPAP, BiPAP. Depends on what you carry, if you have a BiPAP or CPAP. Initially, they start to improve. Then they become tachycardic, hypotensive. Their altered mental status got worse. What do we need to do next? Yes, right. Treat the patient first. Listen to the chest. You listen to the chest right away. You see you have some breath sounds. You hear wheezing on the left. Now there's no breath sounds on the right. What just happened? Tension pneumo. What should we do next? Decompress, right? And then what else should we do? Do we keep them on the CPAP, BiPAP? Yes. Take them off the CPAP, BiPAP, put them on supplemental oxygen, decompress. If you still got the inhalers, keep the inhalers going. We already given them MAG, we already given them epi. Now we just need to haul butt to the hospital, okay? Say that we didn't catch the pneumothorax, right? This patient became hypotensive, tachycardic, and arrested on us. And this patient, say, was intubated already. What are some things we need to do? They've arrested on us. So this is where it's a little different, right? You want to jump straight to your cardiac arrest algorithm, but I would say in these patients, say it's an asthma exacerbation patient or a COPD exacerbation patient, you want to disconnect them from the ventilator. You want to squeeze their chest a little bit. You want to get all the air trapping out. You want to look at the tube, make sure there's no kinking or anything like that. Was this a respiratory driven arrest? All right. And then I'm not sure how Dr. Ferguson feels about this, but I will decompress both chests. If they're already arrested, decompress both chests. If you don't know if you have a tension pneumothorax or not, okay? If you're a physician, bilateral finger thoracostomies. And then, if none of that is working, brought it back, you progress to your cardiac arrest algorithms, okay? Because obstruction is the biggest thing, right? Did we just air trap so much where we're fighting the ventilator? Did we just cause a pneumothorax? Is there a kink in our tube making resistance worse, right? Work through that. This is different from like your regular cardiac arrest patient. And I'm sorry, I forgot to mention this too. These are the patients you want to get stat labs on because we've been giving them albuterol continuously, right? What happens when we continue to give patient albuterol? Which way? It shifts into the cells. So what would it cause? Hypokalemia. So we got to make sure, was hypokalemia the reason the patient arrested, right? So don't forget about that too. Like maybe we had everything right, but we gave so much albuterol, patient became hypokalemic and arrested on us. Okay? So keep that in the back of your head as well. So in this patient, most likely pneumothorax from bleb. We put after being placed on the positive pressure ventilation, we did needle decompression. Then we took the patient off of CPAP, BiPAP. Patient's tension pneumothorax improved after we decompressed it. hemodynamics, the dynamics improved, and we got him to the hospital. Any questions on that case so far? All right, third
Hey,
case.
Just real quick, kind of back up to the beginning of case 2. Did we ever establish that we heard wheezing before we started? It just occurs to me that,
Yeah. Well, I forgot to put it, but yes,
yeah,
wheezing
it's
as
just,
well.
to me, that's a significant point to make sure everybody understands to only give the albuterol here
Wheezing.
wheezing or
Yes.
see bronchoconstriction on our capnogram. And how do you feel about using the capnogram to kind of indicate the effectiveness of the bronchodilators? Is that something you regularly do?
I haven't. I kind of look at the patient mostly and listen to them again if they're improving, but maybe. But I'm also having
For
experience that.
me,
Yeah.
I'm half deaf and I've always had really poor, really low quality stethoscopes in the field and bad environments. So me, the capnogram is more objective. I trust it more than I trust my hearing. Just, I mean, it's just another tool we can make use of. Lets us know if bronchoconstriction is really the problem.
I mean, I'll pay more attention to that. I haven't really paid attention to the capnogram in these albuterol asthma COPD.
Yeah, it's great if you just look at it. Sometimes in the ER, it's tough for us to get that because we get a number, and sometimes by the time we get the waveform, things are moving in the right direction.
Mm-hmm.
Just the other thing to think about is remember, 67-year-olds are going to have other health problems as well. So a lot of times I see a mixed picture of
Heart
COPD,
failure.
CHF, maybe a pneumonia. Patients don't read the textbooks and listen to our lectures. So sometimes they're more complicated than we make them out to be. But I will say that these COPD asthma cases are very challenging, very challenging. The older folks are more risk to having blebs and getting those tensions, like you said.
Mm-hmm.
Younger folks are less like that. Just these are very challenging patients to manage. I think some of the scariest ones I see are the asthmatics that are
Exactly.
tough to manage. I'd also say that I very rarely see giving someone enough albuterol to drop their K where it's critical. And sometimes in kids, you run, 24/7 nabs on these folks. And now they get the hypokalemic, but it's not bad. But these are challenging patients to
Yeah.
manage.
It's just something to keep in the back of your mind when you're going through your progression, I would say. This is more for our critical care folks or the ones in the ICU.
Yeah.
Another thing I would say, what I like to do, because the asthmatics scare me. When the asthma exacerbation comes in, that's a scary thing. They're anxious. You want to put some anxiolysis on them. This is where you will get on with your med director and try to give them some dissociative dose of ketamine, because ketamine also allows bronchodilation and also helps them calm down. Or if you have Precedex, if you're a critical care, start them on a Precedex drip. Because as you get them calm, as you get them to relax, their breathing is going to improve as well.
Yeah, so ketamine is a great drug for someone who's had bronchospasm. The caveat to that, it's a great drug if you're able to take their airway with a sedative and a paralytic.
So that's why I said talk to your medical director before you do
Yeah,
that.
for critical care folks, if you can't do that, it can make it more challenging, super scary.
All right, so our last case, this is going to be a pediatric case, right? 10-year-old male, respiratory distress, show up to a park, the child is tripoding, has audible wheezing, heart rate is 90, blood pressure is 100/62, satting at 88, their tachypneic at 27. This is all on room air. Kid is anxious, appearing bilateral wheezing. Mom tells you my baby is 40 kilograms. What do we do next? She's a good mom, and she keeps. She's from England. The World Cup was happening. The World Cup just happened. We got all these folks from over the seas. Oxygen, albuterol. How much albuterol would we want to give this kid? Yeah, 4 to 5 milligrams max dose. Okay. Technically, okay. And then do we give him mag? How much does he weigh for epi? Max dose 0.3 IM. He weighs enough for that. Say we do have to give him steroids. How much will we give him? Got PD stat as well. Use your lifelines. Use your fellows. What is the dose per kg that we give for steroids? So 2 mg per kg is the dose, right? What's the max in the state of Alabama? 60. 40. what is the dose that he comes out to be? This kid comes out to 80. So will we give him 80 or 60? 60, because we don't go over the max dose, all right? So you give him 60 of steroids, 5 of albuterol, 0.3 IM epi, and patient starts responding. We take him to Children's of Alabama. Everybody's happy. His team lost the World Cup, so he was sad. Questions? So, like I said, these are the patients that scare me the most because these are the patients that could easily crump and they don't follow our regular algorithm. So what we do at the beginning, how we approach these patients at the beginning helps us with what happens towards the end. And sometimes we don't have to get to that level, right? Treat your patients, don't treat the numbers, and make sure you always make them feel calm. Yes. I would say, I'll say trust the medicine, trust the physiology, right? Like you're doing everything right. You're not hurting the patient, right? So if you start them on doing EPs, you're already worked on a path to helping them, right? Now, if they're not improving, putting them on CPAP, it's not going to hurt them, right? Unless you have attention physiology, but we could do something about that. We could fix that, right? Us doing nothing is going to make things worse. So starting them on doing EPs, giving them steroids, giving them some MAG, give them some supplemental oxygen. We're not hurting these patients at all. I would say let's start rolling towards the hospital too. Let's not wait on scene too long on these patients. Start rolling, and if you have to upgrade to a CPAP or a BiPAP, if you have that, better, fine. Because most of the time when they come to me, I'm more likely to be like, hey, we need let's get this patient on BiPAP. I got more resources, I got more help with me, of course. But let's get this patient on BiPAP. Let's see what's going on. But I also don't want. My lecture was on asthma COPD, but like Dr. Ferguson brought up, don't anchor yourself on just that, right? These patients can have a lot of other things. It could be a CHF exacerbation, but action towards the right process of the disease is going to help, but inaction isn't going to help. Okay? But also, don't be too gung-ho, yeah, right? Like I'm moving straight to intubation. Like, nah, we got a lot of things we can do before that. A lot of things that will help them way before we get to that point. Exactly. And so when I was an intern, like, oh man, I'm getting ready to intubate a patient, I would get excited. But as I got a second year, third year, as I became an upper level, I realized how dangerous of a procedure intubation really is. I'm just thinking about like, oh man, I'm gonna push the tube through, patient's gonna be breathing on their own, they're gonna be good. But we're not thinking about the follow-up process. Like for an asthmatic, intubation is like the very last thing. I'm going to do my best to get everything I'm getting on board before I even get to that point on an asthmatic patient. Because I'm either going to more than likely might kill them, or they're not going to ever come off the ventilator. But like putting a patient on CPAP, giving them the drugs, they're going to get better. Like I said earlier, right? CPAP, the positive pressure, you would think is working against it, but it's helping them with their accessory muscles, right? They're tachycardic, they're hypertensive. Why am I giving them IM epi? Unless they're elderly and have a cardiac disease, you give them IM epi, the bronchodilation is going to actually help with those numbers. They're going to get calm, they're going to get better, they're going to be able to breathe better. Okay? So everything has a reason behind it. So that's why these lectures are great, right? Like us getting to know the pathophysiology, why we're doing things, so it should give you more confidence on like, this is why I should do this, and I could back it up. I could tell you why I'm doing this instead of just following an algorithm.
Yeah, great lecture. I agree. The asthmatic patient that's critically ill is very scary. In the Birmingham region, there's probably a handful of those a year, and I would say there's 2 or 3 that pass away. The different types of asthma, there's like you talked about, there's exercise induced, there's allergy induced, and there's a real significant disease out there called asthma as well that those folks get sick. Be aggressive. I would argue there is no max dose on albuterol or ipratropium bromide. So even for kids, there's a max dose listed. There's no way to tell how much of a dose somebody's actually given. So limited risk, great benefit. And young people that have the respiratory distress, the wheezing, IM epi every 3 to 5 minutes, you really can't overdose them either with that. So be aggressive with those things. CPAP, BiPAP, if they're working, great. If they're not, you can always take them off. But if they're not working, that probably means you're going to have to do assistive ventilations. So you're going to be going down that same rabbit hole anyway. So The other advice or suggestion I would make is have a good relationship with your online med control or your offline, so you can phone a friend and ask for advice and questions. With today's technology, you can FaceTime your doc or your med control real quick. It needs to be HIPAA compliant. Let me rephrase that. I have to say it needs to be HIPAA compliant.
A work phone.
Right. But you can do that and get that information. For the critical care guys, if you've ever transported somebody with severe asthma, those guys are challenging. Ketamine's great, like you said, for sedation. Sometimes you have to paralyze them, and it's ketamine, it's propofol, it's an epi infusion, low dose, and it's reversing your ventilator strategies so you have more expiration, and it's very challenging. But the key thing is know how the medicines work, know how to figure out what's going on with your patient, have that resource where you can phone a friend, because at some point in your career, you will see somebody sick like this.
Exactly. And like if I'm the online medical director, you call me, I'm gonna walk you through this because we're in this together, right? Like that's the job, to help you through this and tell me the picture. I'm visualizing myself there. We're gonna do this together. Like, all right, let's do this next step. Let's do this next step. You're doing everything. Sometimes the reassurance is all we need. Like, you're on the right track. You're doing the right thing.
So we got a couple of questions came in online. I think you answered the first one several different ways, which was about what if the patient is too altered for CPAP, then obviously we have to go to more advanced airways. The second
Yeah,
one,
I'll say one thing on that. Sorry. So if they're too altered for CPAP, that probably they need assisted ventilation. So sometimes you can cheat and use nasal trumpet with your CPAP mask to hold a good seal so you can help ventilate those folks. So we use a lot of BiPAP in the hospital because we can set a rate. So even if they're a little bit altered, we can sit there and watch them, and it's almost like bagging the person for a while in the hopes to bridge that gap, to break them up, open them up so you don't have to intubate them.
Well, since that's why I like BiPAP, I think if you have the ventilator, if you have the resources, so
right,
that's the thing. If you have the resources, if it's just you back there, trying to bag them probably will be the best.
Yeah, and that's gonna be complicated to do. But
you know,
they got ventilators now that are less than 7K that can do BiPAP and so forth, and so it's a relatively cheap resource compared to other things that we buy in EMS.
For the bang for your buck,
Bang
for the
for your
benefit that you're getting out of it.
Yeah. All right. Sorry, Chief. I didn't mean to interrupt you.
Oh, no, good information. So the other question is, looks like a critical care question. Our service recently started carrying levobuterol.
Yeah.
Probably pronounced it wrong. For critical care, what patients would most benefit from this, or when is that drug indicated?
Yeah, so it's another derivative of albuterol, but it has less side effects, so you get less tachycardia with it. So it's more geared toward that person that's going to be on albuterol for hours.
The whole transport, basically.
Yeah, or for people that are older and have heart disease.
Yeah, I was going to say, it sounded like that'd be a great choice for the 67-year-old in
right.
Doc's case.
Yeah. So,
yeah, the 67-year-old makes me nervous because, is this a STEMI? Is that why he's having trouble breathing?
Is this flash pulmonary edema? Is this what? It's a lot of things that can
happen. And it
happen.
can go both ways too. They could be having their COPD exacerbation with underlying maybe asthma type stuff, and now they're having heart disease because their heart rate's 140 for the past 4 hours.
Exactly.
Hypoxic. So
this is a dialysis patient that didn't go to dialysis, right?
Yeah.
So.
Very good. Great lecture. Thank you, sir. Hey, everybody, we're going to take just a few minutes straight of a break to get everybody a chance to stretch your legs, go to the restroom, whatever, and we will be back with Dr. Pittman in about 5 minutes.
All right, y'all. Thank y'all.
Hey everybody, I'm Dr. Pittman. You can call me Liz. I'm a second-year resident at UAB in the emergency department, just finishing my EMS rotation. So I'm going to be presenting on non-traumatic back pain today. Just a little bit about me. I'm from South Georgia, near the Valdosta area. I'm from a small town, about 5,000. We have 2 rescue units in my hometown, and they just got AEDs about 2 years ago because someone donated them. So we're very behind in EMS times, but I'm hoping to revamp that. Here are our learning objectives. My goal today is when you get dispatched on back pain, that it's not like a shrug and like, oh, I have to get a back pain. I'm hoping to make this, more informative on the 6 things that you can't miss, the absolutely life-threatening causes of back pain. And I'm hoping that you can be able to differentiate between the sick versus non-sick patient that has back pain after the end of this lecture.
The lecture is going to kind of go in order of, we're going to do a first case, talk about some statistics, talk about history and physical and how you can do your initial EMS assessment on these patients. Then we will talk about can't misdiagnoses, some common benign diseases for back pain, and then we'll wrap up with several cases and some multiple choice questions. If you guys have any questions or anything, just stop me. All right. Our opening case. You are at the fire station, you get dispatched out to a 67-year-old male with severe low back pain. That's all you got. You don't have these vitals yet. You are just thinking, oh, you know, another one for transport. So you get to the scene, you finally set up, you get your vital signs. You see your patient has a heart rate of 112, he's hypotensive, respiratory rate of 24, but no reported trauma. What are you thinking? Yeah. This is one of those surprises, right? You think you're going out for severe low back pain and you get there, you see these vitals and you're like, whoa, this is serious. Yeah, probably impending doom. So that's a ruptured AAA. So that's one of the most life-threatening causes of back pain that we have. Some statistics just for you to realize how important this is to the emergency department. We see this is about 3 to 5% of our visits annually, about 2.5 million visits. Numbers wise, 90% of it is benign, so degenerative disc disease, herniated disc, sciatica, but we can't miss that 5 to 10% that can be fatal. So initially, when you get to the scene, you're going to take your quick history. You're going to size up the scene, get vital signs, think about, you know, what could be going on. Does this patient have a history of recent back surgery? They tell you they haven't fallen. You're thinking, you know, are they an IV drug user? Do they have a fever? Are they a cancer patient? You know, all the different things that could lead you to one of those life-threatening diagnoses. What happened before the pain? What were you doing? Were you lifting something? Were you know, sitting in your chair and it just came on? Have you been having this chest pain and now it's, you know, in your shoulder blades? And then we'll talk through a more focused physical exam in a little bit. How many of you are familiar with this version of history taking? This is what you guys use every day. Okay. So you're going to use this again for these patients. You're going to talk about, you know, like what were you doing when it started, onset, how long has it been going on, what makes it better, worse, movement, no movement, can they get comfortable, does movement make it worse, sharp, dull, burning. These patients are probably just going to tell you that it hurts. They're probably going to be mad when you start asking them their pain score. Does it go anywhere? And then how long has it been occurring? These are a list of associated symptoms you can ask about. We talked about fever, if they have any like neurodeficits like weakness, saddle anesthesia, do they have cancer, abdominal pain, just the things that you don't think about. Saddle anesthesia is in the crotch area. If you have any, like, you can't feel when you wipe, when you go to the bathroom, you can't feel when you're urinating, you're not able to control your urination. Those are all associated. So this, like I said, these are probably the most important questions that you're going to ask. Have they had fever recently? Are they a cancer patient? IV drug use, surgery, steroid use, numbness, weakness, difficulty urinating, or any weight loss. So physical exam, I know we already talked about back pain. You're probably going to examine the spine. I think something really important that we don't talk about enough is the different organ systems that can cause back pain and the physical exam that goes along with those. So we're obviously thinking spine, we're thinking musculoskeletal, we're thinking neuro, we're doing some weakness, some deficit testing. The other things, CVA tenderness is a big one that I feel like I oftentimes forget to include. The urinary system, abdominal pain, like pancreatitis can cause back pain as well. But you can test motors. I typically, like, if you can get the patient to walk to get on the stretcher, great. You've already assessed that they are stable. They don't have balance trouble. They can feel their legs. I feel like that is a good test, easy test to do. The other one I think is do grip strength. Do they have any spinal tenderness? If they do have spinal tenderness, is it in the middle? Is it right on their vertebrae? Or is it paraspinal, like on the sides? Does it feel like tightness on their sides? Do they have a muscle strain? Those are all different things that are going to tell you, kind of narrow down your differentials. Red flags. We already talked about a little bit of this. So fever, infection, you're thinking epidural abscess, osteomyelitis, discitis. If they've had any IV drug use, we're thinking this too. Neurodeficits, obviously bowel or bladder control. We talked about the saddle anesthesia. Cancer history, you're thinking, is this breast cancer that's metastasized to the bone? Is this, bladder cancer they don't know about? Like, what are we, finding? A lot of times this can be their first presentation and they already have metastatic cancer. Older age, we're thinking more fractures, some benign causes, cancer and AAA. And then are they on any anticoagulation? So I know we talked about this is non-traumatic back pain, but how many people have gone out to dispatch and the patient said, yeah, I just bumped my head a couple days ago, or yeah, I fell, but I didn't think anything of it. They're going to tell you they haven't had any trauma, and then when you start talking and when they get to the ER, they're going to tell the nurse the opposite. So we've had that quite a few times. So as far as the can't miss diagnoses, there are 6 that you should be concerned about. We'll start off kind of most aggressive with AAA. So AAA, it's a progressive abdominal aortic dilation of 3 centimeters or more that predisposes patients to rupture. The risk factors are smoking. I've got some numbers for y'all. Current or ever smoker. So you might have a patient that said, yeah, I smoked, I quit in my 60s, I haven't smoked in 5 years. They're still at risk of having a AAA. Matter of fact, current or ever smoking has a 3.4-fold increased risk of AAA. Mortality for rupture AAA is 65 to 85%, and about 50% of these patients will rupture and die before reaching the hospital. The presentation, we typically see older age, male sex. Some of them have a family history of a AAA. Some of them have other coronary artery disease or vascular disease. They can be asymptomatic, and then you can see the patient that's ruptured, like that first case we saw where they're hypotensive, tachycardic, and obvious distress. But you're hoping that you catch them asymptomatic and that you can get them to the care center they need. But they can oftentimes not have chest pain or abdominal pain. They might just have low back pain. You can see a pulsatile mass. I don't think I've ever seen one on all the AAAs I've seen. I've never noticed pulsatile mass. And then you're hoping they're not hypertensive when you get there. Treatment for these, we are going to treat this patient like we would any bleeding patient. Like they have a risk for ruptures. You're going to get 2 large bore IVs. Oftentimes in the ER, we're going to do a point of care ultrasound. So the sensitivity for that is 97.8%, and specificity is 97% for detecting it. If they're stable, we're going to get a CT angiogram just to look at their vessels for surgery and for our vascular surgeon colleagues. And we're going to allow some permissive hypotension. I don't expect you guys to do this en route, but we're going to try to get their systolic lower than 120 just to help from that possible rupture.
Hey, Doc, when you say, when you gave those numbers on reliability and specificity, was that to indicate the presence of an aneurysm or the rupture?
Yeah, so that's just our point of care ultrasound, how good we are with our point of care ultrasound in the ER in detecting these things.
And detecting the aneurysm?
Yes,
or ruptured aneurysm?
The aneurysm.
Okay. You see a time when that might move to the pre-hospital setting?
I think we're kind of getting there with point of care ultrasound. I think that it would be great, especially I think we're kind of looking more at like vascular access more than anything.
Yeah, I think so, because with the AI technology now, you can get an ultrasound that labels anatomy. The big issue with EMS ultrasound is the fact that you can't run through an ER and scan 30 people and have somebody look at the images with you and say this is normal, abnormal. With the new AI technology, it labels things. So as long as you can recognize normal and AI can label it, you can find abnormal. So the short version is yes, I think we're almost there. Yeah. You can get this technology for less than $5,000, and the training had been the biggest issue in the past. Now training can be done pretty easy. So yes, yeah, we're getting there. Yeah. Yeah.
I know you love ultrasound. Like I said, the EMS priorities, rapid detection. We can do permissive hypotension en route. Obviously, if you think they're ruptured, that's a different story. But we like to keep their systolic down if we can. You can do that by simply treating their pain. If they're having pain, they're anxious about this, you can go and give them some fentanyl. and try to at least calm them down, like we talked about with asthmatic patients. That will help in this scenario too. You want to avoid giving them tons of fluid. These are not patients that, if you have a high clinical suspicion of this, if they have a family member or they have a known AAA that was, not treatable with surgery in the past because it was too small and you think they might have ruptured now, these are the patients that you want to think about not giving them aggressive fluid repletion. And then you want to make sure when you're transporting these patients, you don't want to just take them down, to the freestanding ED. You want to take these patients to a vascular center where they can have a vascular consult and go for surgery if it's indicated. So this is a picture of a AAA just so you can see it. It's just that ballooning out effect. That's why you can sometimes see the pulsatile mass, but I would assume that would be large if you could see it in most of our patient populations. Aortic dissection is the next can't miss diagnosis. Dissection is just a tear within the wall of the vasculature. These patients typically tell you it was sudden onset, this ripping, tearing sensation that just came out of nowhere. They were just resting when it happened. You can have it migrate, like I said, the shoulder blades earlier in between the shoulder blades. It can go all the way down to the groin. It can go up to the neck. These dissections can just expand beyond the point of initiation. So pulse deficits, I often hear, like I talked to some paramedics about this week, what do they think about aortic dissection? What's the first thing they're going to notice on physical exam? And we talked about pulse deficits. But you can see these only appear in about 15 to 30% of patients and only about 20% sensitive. So if you're thinking, just because I don't have a pulse deficit doesn't mean this isn't a dissection, that's not accurate. You want to make sure that you're still not ruling this out just based on you don't have a pulse deficit or you don't have blood pressure differences in the arms. These are definitely things that, yes, if you have them, 100% high clinical suspicion that you have a dissection, but just because you don't doesn't mean that's not what's happening. Treatment. We're going to do impulse control typically in the ER. So we're going to keep that systolic down, like I said, for the aneurysm, we're going to keep it down less than 120. But we're also going to do, like I said, impulse control where we give them IV beta blockers like Esmolol, and we keep their heart rate around 60 to 80 because that's going to help from the dissection going further. We also, these patients are coming in, these are patients I would probably get a D-dimer on if I had a suspicion, and I wanted to rule this out and say, I have this patient that's comes in with, severe low back pain. I think it's probably just a herniated disc, but if I get a D-dimer and it's negative, that's going to help me rule these things out. The patients that are stable, you're going to get that CT angiogram again, like the aneurysm. We kind of treat these very similar. And then we're going to talk vascular surgery. And there's two different types. The first type A dissection is before the aortic notch, and then the second is below. So the A type is always surgery. That's always the answer, acute surgical intervention with vascular. And then the second type, it just depends on how large it is and how much of the organ systems it's affecting. So obviously if it goes down to the renal arteries and they're having an acute kidney injury and you're seeing, end organ damage from this, they're going to have surgery. But sometimes these can be treated with medical management, like beta blockers. You kind of treat it as a hypertensive patient. Yeah, the question is about vascular surgery, putting a sheath over these dissections. Yes, we definitely do. I've definitely scanned patients that had chest pain and they have had, multi-vessel disease and they've had sheaths placed. I think it's typically called an EVAR is what they describe as their surgical operation that they've had. So those patients are, I still have a high suspicion that they could have another dissection if they're already prone to it. So we'll kind of see it's like a almost like chicken wire around the aorta. So you can definitely see, the question is about on a 12-lead EKG if you can see any changes for these dissections. I don't think there's any specific changes on the 12-lead that are just diagnostic of a dissection that I can remember, but you can see ischemic changes for sure. You can see some T-wave changes.
Yeah, sometimes that'll dissect back into the coronary arteries itself, into the cuffs, so you'll see what looks like a big left main STEMI or left main occlusion or a right coronary. And a lot of times, I won't say a lot of times, sometimes these are found, they go to the cath lab with their chest pain, ST elevation, they squirt the dye in there and they go, oh, well, crap, the problem is not there's an occlusion, they've dissected back into that. And that's why places that are cath lab capable hospitals that do interventions have to have a CV surgery person on call or a transfer agreement. So if they go into cath somebody, they go, oh crap, it's not an occlusion, it's a dissection. They can pull that wire and ship them and do surgery right then. So you'll see elevation too. It looks like a STEMI, right? It does, yeah. So you can see that, yes, sir. Yeah, but there's no way to tell without going in, doing a cath, or getting the CT angio images. There's no way to tell in the field. No way for me in the ER to tell it either. You would not be able to know it's not a STEMI until they get to the cath lab. Probably not really. No. Yeah. And I know we're not talking STEMI care, but I mean, I would use in STEMIs if they're really hypertensive. I'm doing nitro to lower the blood pressure and control the pain, and that would help with this. If they're not really hypertensive and they're having chest pain, I'm getting their aspirin. I'm moving to that cath lab hospital, and I'm probably doing some fentanyl and morphine for the pain first. So yes, sir.
Yeah, we did have somebody point out online that there is a Alabama critical care protocols to address pre-hospital lowering heart rate and blood pressure for suspected.
Yeah, a lot of times I feel like when we see these come in to UAB specifically, I've taken a lot of transfers for these, and they're already coming on an esmol drip or a clofidipine drip or nicardipine, just to kind of keep that blood pressure down. So they're already initiated in transport, and they just have to continue that. Obviously, if a patient is already bradycardic or their rate can't really handle the esmol drip beta blocker, then we can just do clofidipine and keep the systolic down. Moving on to Cauda-Equina syndrome. So this is a compression of the L2 to L5 spinal cord. This is the patient that I was talking about where you'd see the saddle anesthesia. Specifically defining this can be one of more of the following. You have either the bowel or bladder incontinence, so they're either urinating on themselves or defecating on themselves. They have saddle anesthesia, or they describe sexual dysfunction. They can also have possible neurodeficits in the lower limbs, but this typically comes later. Oftentimes, the first thing that patients actually notice is urinary retention. So they haven't had urinary retention in the past. You get them into the ER, you bladder scan them, and they have like 500 or 600 in their bladder. These patients sometimes will also do a post-void residual. So we'll scan their bladder, see how much is in it. We'll have them urinate and come back and see how much is there. And that oftentimes tells the neurosurgeons what they need about how much this is affecting them. So I've had patients before come in and say, hey, like an outside hospital told me I thought that I had Cauda-Equina. There's a 48-hour mark. This is readily available on Google. So what they're talking about is when the symptoms onset, typically the best benefit is surgery within 48 hours. There's actually a study done in 2026 that had 26,000 patients. And it was a meta-analysis across multi-centers, and they showed improvement with the 48-hour mark and the 24-hour mark. So surgery less than 24 hours didn't have any outperformance of the 48 hours. So that's why these patients, when they're seen on outside imaging, they get transferred to a hospital like UAB or a center that can have these neurosurgery capabilities. And that's why it's so important to get them in, get the MRI, and get them to surgery, because after 48 hours, they don't get that neuro recovery as well. Next is a spinal epidural abscess. You can see the kind of red blob shape there. That's the epidural abscess we're looking at. It's an infection specifically between the dura mater and the osseous or ligamentous structures of the spine. Patients that have a history of IV drug use are at risk for this developing. It's often Staph aureus is the bacteria that we're seeing cause this. They have a classic triad when they present. It's fever, back pain, and some neurodeficits, but oftentimes their diagnosis is delayed because the fever comes later, or they notice that they felt ill and they can't really place it, and by the time they come in, it's past the window. So like I said, their best neuro recovery, similar to Cauda-Equina, is in 48 to 72 hours, but oftentimes they don't present for like 2 weeks after they've noticed. Back pain occurs in 80% of these patients, but you can have neurodeficits in 20 to 47% at diagnosis, and a third of these patients, like I said, come in 2 weeks after it's kind of started, because they don't really mount an immune response until then. And so treatment for us, we're just going to focus on broad spectrum antibiotics. We're going to get an MRI, and we're going to talk to neurosurgery about possible intervention. I've seen this happen in patients who have had previous spinal surgeries, so definitely look out for that too. So this is one that you're going to feel, isolated back pain. You're going to examine their spine. They're going to be tender. They're going to have a fever. Just never rule it out. If you have a patient with back pain and a high fever, don't rule out the septal abscess. They're not always the most truthful about their recreational history. Vertebral osteomyelitis is just what you think it is. It's osteomyelitis of the spine. This is typically not a primary source of infection. It's typically from things like endocarditis, UTI, dialysis catheters, PICC lines, just any indwelling line that you can think of. It's also typically Staph aureus that's causing this. But our treatment's a little bit different. We're going to go in for the MRI. If they're septic and neurologically compromised, we're going to go ahead and initiate broad spectrum antibiotics. Surgery is an option, mostly for debulking this infection and making sure that their spine is stabilized, but it's typically not for really source control because we're not going to be taking any of those vertebrae out. This is another one that's really hard. Once you have osteomyelitis, it's really hard to get source control. They're typically on broad spectrum antibiotics for several weeks to months at a time. Last, but significantly, definitely not least, is malignancy. So spinal metastasis is typically what we're talking about. There's not many primary cancers that really start in the spine and kind of move outward. So this is most commonly lung, breast, or prostate cancer. The thoracic spine is definitely the most common, with it being 80% of metastasis. You can have also lumbar and cervical spine, but those numbers were a lot lower. This is typically important because about 20% of patients get their cancer diagnosis just from that initial back pain presentation. So you could be, having a patient come in low back pain, you get x-rays, you scan them, you see, pathologic fractures, you see, what you think is metastasis, and then they get full body scan and realize like, oh, this is primary lung cancer, oh, this is primary breast cancer that they just didn't know they had. So moving on to common benign diseases. These are all of your like wear and tear of the spine, things like that you see that are a little less emergent, but still to patients they're going to be 10 out of 10 pain, dying, coming in, they're they're uncomfortable. They want to be treated as soon as possible. So starting off with compression fractures. So these are typically fractures of the vertebral body, and they have bone collapse. You can see in this picture that they have the fracture and their whole vertebrae kind of collapses down. There's 3 different types. You can have wedge, biconcave, and burst. These are typically most common in your elderly patients or your postmenopausal women. So if you have a patient population like that you're thinking, oh, non-traumatic back pain, this is what you can think of as one of your differentials. It's most common associated with osteoporosis, but it also can result from trauma or malignancy. Treatment for these, we're typically going to get x-rays first. If they have a burst fracture, we're going to get further imaging. We're going to do pain control. So typically we start with NSAIDs, so like your ibuprofen, your naloxone. You're going to do those, naproxen, sorry. You're going to do those first because there's really no benefit in narcotics versus the NSAIDs, is what several studies have found. You're also going to be careful in this patient population. If we're talking about the elderly patients, you're not going to want to start them on like oxycodone because they're going to be fall risk. They might have polypharmacy from other things that they're prescribed. So you really just want to be careful sending them home on narcotics. We can also do calcitonin. There's been limited studies that show some evidence that this helps reduce pain, but it's really mixed pictures, just like bracing. So like if you get a back brace, it's just a mixed picture. It oftentimes is just that placebo effect for the patients, and it just gives them some reassurance that they're stable when they're going about their daily activities. Another one we don't think of often is renal colic. This is just severe pain that's caused by an obstruction in the urinary tract. So the red area that's outlined here is the path of the ureter. So any obstruction there, you can have pain that radiates from like the CVA area, where you're going to do CVA tenderness test, and it radiates all the way down to the groin area. These are oftentimes caused by stones. We talk to patients all the time about how we're going to treat their stones. Typically, we focus on pain control first, so that's going to be with Toradol. It's typically the most effective. You can do 15, 30 milligrams. There's some studies out now that show there's really no difference in pain control with 15 versus 30, so you can always just be conservative. You can use 15. These patients are probably going to get imaging, urinalysis, just to make sure it's not an infected stone, because that any infected stone at any size requires urology to see them. We're going to give them like Flomax for 30 days. There's typically a higher chance of passing the stone at home if it's in that 5 to 10 millimeter range or less. You can pass it at home with the Flomax. It's just an alpha blocker, so it kind of helps open up the urinary system to pass the stone. So less than 5 millimeters, we're sending them home. 5 to 10, kind of depends. We can do the medical expulsive therapy like the Flomax, and they can be observed if they like are having profuse vomiting, they can't keep anything down, they're having trouble, moving around just due to pain, or they're having to have like push dose medications in the hospital, like the Toradol is just not helping. And then greater than 10 millimeters, signs of infection, or typically we don't really see acute kidney injuries with these patients because the other side of the kidney that's not obstructed, the other kidney, is going to compensate, so you don't really see a bump in their creatinine. But if you do see that, that's another reason for them to stay and have urology assess the patient. That's all I had for that one. Pyelonephritis is another one. I don't know if you guys can see all of these words on this graphic, but I thought this was a great one just to tell you the difference in like UTI versus pyelonephritis, just for quick management. You're typically seeing pain just from the bacterial infection of the renal pelvis. It's like a visceral pain, and that's just from the migration of the bacteria up from the bladder up into the upper urinary tract. So we're talking about more systemic symptoms. These patients don't always have a fever, but they have flank pain, so in the back. The UTI is typically in the front, suprapubic pain. You can also have both with pyelonephritis. You're having the urinary symptoms that you typically think of with the UTI, the pain with urination, urinary frequency, the urgency, and maybe some blood. With pyelonephritis, you're not always having those. They could have had them a couple weeks ago, and now they're not, so don't always rule it out just because they're not having urinary symptoms. These systemic symptoms are typically my trigger to think pyelonephritis. If they're having fever, chills, nausea, any vomiting, and if they just feel achy all over, that's kind of my, like, okay, this is a kind of more systemic now. I need to be thinking about treating this a little more aggressively. You can get labs on these patients, obviously, and then if we're thinking that they're septic in any way, we're obviously keeping them. We're going to support with antibiotics, and it just really depends on their clinical presentation. If they have pyelonephritis, have no like comorbid conditions, they're young, healthy, we're going to send them home with antibiotic therapy for 7 to 10 days. If they are more septic, have those surge criteria, like they have fast breathing, fast heart rate, a white count on their labs, or if they have a high fever, we're going to be keeping them if they have 2 out of 4 of those. And or if they have any reason, like if they're like intractable vomiting, they can't go home and take PO antibiotics, we're going to be keeping them in the hospital just to give them IV and just to give them time hydration and repletion. Pancreatitis, like I talked about earlier, can give you back pain as well. The typical causes and triggers of pancreatitis are listed above. So like gallstones, you hear alcoholic pancreatitis a lot. Those are the patients that you see come back frequently for pancreatitis. Hypertriglyceridemia, you can have trauma or a malignant obstruction from pancreatic cancer. Typically, medications I feel like I see less likely as a trigger, but some medications that we see a lot, like Lasix, statins, GLP-1s, they can also cause pancreatitis. So just be thinking about those if you have somebody that has that like epigastric pain that's radiating to the back, it's better with leaning forward. Just be thinking about, okay, did they just start any of these medications recently? For us in the hospital, we're going to start giving them fluid repletion. There's some kind of mixed thoughts about if they can eat or not, but typically if they can control their nausea and vomiting, we can start feeding them by mouth, and then we're just going to keep treating their pain until we kind of get the inflammation down. There's no real need for antibiotics in this case. I think in the past there was prophylactic antibiotics that had been administered, but we're not doing that anymore. All right, another one I feel like we don't think about often when we talk about back pain is shingles. This is just if you've had the chickenpox before, the virus is actually latent in your dorsal root ganglia, and then it can pop up in times of stress. I had several friends when we started medical school that they started having a shingles reaction just from the stress of starting a new school and just all the things that we were going through in the first year. It's typically a dermatonal burning, tingling sensation, and itching. That typically starts before the rash. So if you have a patient that's having this pain, you might not always see a rash. They still may have shingles. So just be careful. It's typically on one side. Be careful if you or your partner are pregnant or trying to get pregnant. Be thinking about this. This is not only contact precautions, but also respiratory precautions for patients. Just be careful. Make sure that you're wearing masks. Make sure that you are assessing for that when you get there, because you could have to be treated with the antibody for this, especially in the first trimester and second trimester of pregnancy. Treatment, we're typically giving these patients antiviral therapy. They're getting about 7 to 10 days. If they have recurrence after that, we'll do a longer treatment course. They are getting pain management. We'll do like ibuprofen, Tylenol. Lidocaine patches have surprisingly worked well if they can tolerate them. And then we do some gabapentin for that neuralgia type pain. Some different emergencies that I won't go into too much detail on, but just to think about. So like the herpes zoster ophthalmicus, that's when you get the herpes zoster in the distribution with the eye. That can be an ophthalmologic emergency. Ramsay-Hunt syndrome, and then you can also have like meningitis or encephalitis from varicella zoster. So how do we typically talk about this rash? Do you guys have like a little phrase, a catchphrase that you say to yourself when you're thinking about a shingles rash? We typically call it a drop on a rose, is what you're typically describing. So you can see they have like the vesicles that are on an erythematous background. You can see the picture with the early stage, the mid stage, and the late stage really pops out. If patients have had the shingles vaccine, they can still have shingles, but their reaction is much more mild. So it's very hard to diagnose. I've seen some of these rashes myself and, not been able to distinguish it from like insect bites. So just be careful. Just always have it on your differential. That's typically how we describe it. Lumbar strain, one of those that you hate to have and you hate to see because we typically can't do a lot for these patients. It's a stretching or tearing of that ligamentous spine. Patients complain that movement is worse. They can get comfortable if they're sitting or lying down. When they finally get a comfortable position, they don't want to move. Whereas patients that have like pyelonephritis, renal colic, a AAA, they are constantly moving because they just can't sit still because they're so uncomfortable. So that's one way you can differentiate the different benign causes of back pain. They typically have a normal neuro exam. Pain improves with rest. Imaging is not indicated. We oftentimes, I feel like, get a bad rap in the ER because these patients come in with, they think 10 out of 10 severe back pain. It's a lumbar strain or it's one of these other benign causes. We don't do any imaging. We're really just treating them with hot cold therapy, some ibuprofen, maybe some muscle relaxers, but it's typically not a very satisfactory visit for patients that think there's something else going on or think that we can absolutely, fix their lumbar strain in the acute setting. Steroids are not indicated for this type of back strain. Disc herniation, this is another one, similar treatment. It's just going to be where you have one of those discs is herniated and it compresses the nerve. Oftentimes patients will have that, what I said, the paravertebral spinal tenderness. They have like the muscles that have locked up on the spine. And I mean, you can sometimes see them like they kind of almost like look crooked because they're so clamped down on that one side and they can't move. It makes it hard for them to walk. One of the tests that you can do in transport or that we can do once they arrive is a straight leg test. So you get a patient laying flat, you raise their leg up, and if the pain is worse on the side that they're complaining of, then it's a positive straight leg test, and it just tells you that there's radiculopathy present and that you are compressing that nerve when you lift their leg. It is 92% sensitive, but not very specific. So it's a good screening test. But you can see, we use straight leg tests for not just disc herniation, but sciatica and degenerative disc disease. Like lumbar strain, imaging is not indicated. You just have to educate your patients, reassure them. I find that talking to them a lot and explaining, I've ruled out the 6 causes of emergent back pain for you. It is one of the benign causes. It's not something that we can treat acutely. Steroids have not been shown to be beneficial. Go home. Heat, cold pack, lidocaine patch. If they really want it, it typically doesn't help for this type of pain. And then early mobilization is going to help them, just getting out, stretching, moving, walking. Sciatica is another one of those benign causes of back pain. The pain typically radiates down the posterior leg. It's worse with coughing and sneezing or like any type of bearing down. The treatment, like I said, for most of these benign causes is patient education, reassurance, hot cold therapy. You can do muscle relaxers, pain control with ibuprofen, Tylenol, and then you can talk about a prednisone taper if they've had it consistently, but this is not really shown to have too much benefit, just like the rest of these causes. The patients that I see that I have a hard time with are typically the patients that have sciatica in pregnancy. I've seen several women that come in like their second trimester of pregnancy or the beginning of their third. They have a long way to go and they still have the sciatica, and it is so bothersome to them. They can't move around. You know, it's already hard to get around being pregnant, and they might have young kids at home. So it's typically about 10 to 25% of pregnant women. So that's a pretty significant number. For treatment for them, it's really hard. We struggle. We can do Tylenol. There's limited research that says you can use ibuprofen in the second trimester, but I still don't think that I'm going to adapt that practice. We're typically giving them like the pelvic support band, so it typically goes underneath their belly and it kind of lifts up to kind of relieve pressure on that back because they're constantly having heavy pressure weighing down. You can do exercise therapy, like I said, lidocaine patches, but there's not a whole lot we can do for these patients, but I will see these patients consistently present again and again, like once a week when it just becomes unbearable. Degenerative disc disease is typically patients that are 40 to 70 years old. It's associated with I tell people it's the wear and tear of your spine over your lifetime. 90% of patients will actually have MRI findings by whether they're symptomatic or not by age 69, and then 50% of patients will have signs on MRI under the age of 40. So there's a high percentage of patients that have this. It's common, an incidental finding that's commented on by radiology a lot. Risk factors are age, genetics, smoking, obesity, if you have a job that's heavy in physical labor, and tall stature. So vertically challenged people are at less risk of degenerative disc disease. So that's a plus. They typically present pain worse with sitting, bending over, twisting. So it's all about like grinding of the spine. It improves with standing and changing position. Shocker. Imaging is also not indicated here. You're doing the same thing for these patients. So whether you have a patient with lumbar strain, disc herniation, sciatica, degenerative disc disease, you're treating these all the same. You're not getting imaging. You're doing NSAIDs, hot cold therapy, maybe some muscle relaxers if indicated. That's why patients get really frustrated with us because we're doing the same thing no matter what it is. EMS management. So typically with any of these back pain patients, we're going to talk about getting them comfortable, giving them something for pain control, and then getting IV access for those patients that you really think have the emergent causes of back pain. Like if you think they're having a ruptured AAA and they're hypotensive, if they have a fever and you're thinking epidural abscess, if they have saddle anesthesia, you're thinking cauda equina. Any patient that you think is one of those sick, non-traumatic back pain that we talked about earlier, you're going to be thinking about getting IV access on those. You'll just keep monitoring their neurostatus, monitoring their pain, just keeping them comfortable until they can get imaging and further evaluation in the ER. Speaking of the ER, where are you going to take these patients? So that's oftentimes something that we're thinking about, I guess, early on the scene is, does this patient need to go to UAB because they have cauda equina or they have a spinal epidural abscess, or do they just have simply a lumbar strain or degenerative disc disease that's flaring up and they can just go to their local ER, or even they might not even want to go to ER, they might just want some pain control, and they can be examined and followed up with in the outpatient setting. So high priority, those are your patients that we're talking about earlier, any of those red flag symptoms. Any patient the age of greater than 65 with new pain, I would consider that to be significant if they've had no trauma, if they've had no strain, if they have none of these histories and it's just weird. They're 10 out of 10 back pain. And this is the first time you've been called on them. It's just kind of weird. They just, out of nowhere had this happen. I'd be kind of suspicious on them. Any patients that are on blood thinners, I always ask 5-6 times, like, have you had any trauma? Have you bumped up against something? Have you lifted something too heavy? Did you have recent surgery? Any of these questions, because sometimes they don't jog their memory until they arrive at the ER and then you said, oh, the patient didn't fall, there's been no trauma, and then they tell the doctor and the nurse, yes, there is trauma. We've all been there. But those patients are the ones that I try to quadruple check. And then we talked about the lower priority patients. So just to kind of wrap up, I've got 5 cases and then 4 multiple choice questions. So we'll kind of go through them. Case 1, you get dispatched out. It's this 22-year-old guy. He lifted a couch yesterday. He's got localized lower back pain, normal vital signs. He has no other medical problems, takes no medicines. What's your first thoughts with him? Is this sick, not sick? Okay, so not sick. So what are you thinking is your differential? Okay. Okay. Lumbar strain. What interventions are you thinking about giving this guy when he's in the bus with you? Are you getting access on this guy? Are you giving him anything for pain? Okay. I would agree. And are you running like lights and sirens with him to UAB? Or are you flowing with traffic, kind of hanging out at the local ER? Yeah. Yeah. And then when you call in, if you're going to take him and he wants to be transported, this is like the worst pain he's ever had. He's never had medical problems, never been to the doctor. He thinks this is what EMS is for. What are you going to tell the local hospital when you like call? I think it's important just to differentiate like that this is a like seemingly healthy 22-year-old guy. He's not a sick patient. His vital signs are stable. You think this is musculoskeletal and just bring them. I think it's good not to sway the judgment and let them know like, hey, I do not think this is a AAA. I do not think this is whatever, but just to let them know they're sick versus not sick. They have, underlying medical problems or not. I think that's important in establishing your differentials for back pain. Yeah. I'll to the waiting room. So other things that I'm thinking of for this patient is a herniated disc, a compression fracture if he's older and hasn't had any significant trauma. Pearl on this one is that the pain is reducible with movement and touching. There's no red flags. He has a normal neuro exam, and then you can transport if needed. What about this guy? He is a 45-year-old guy. He admits he's an IV drug user. He has fever. He's got back pain. He's had difficulty walking for a couple of days. What are you thinking for him? I'm thinking spinal epidural abscess. That's kind of the red flags. He's got the fever, the IV drug use history. He's got a neuro exam that's difficult. So he's got that triad of symptoms that we were talking about. Other things you can think of is vertebral osteomyelitis. You can think meningitis, pyelonephritis. It just depends on what exam you get from him. This patient, he's got the progressive neuro symptoms. You're going to get him in. We're going to do typically MRI, broad spectrum antibiotics, and we're going to talk to neurosurgery about how they want to proceed. But teaching point is that if you see fever, back pain, neuro symptoms, that should be like your first go-to. It should be like not pass go. You can't rule it out, and on the way you don't have imaging, you don't have other testing that you can do. So think the worst, and we can always scale back. Next, we have this 74-year-old gentleman. He's a smoker. He had sudden onset of back pain, and now his blood pressure's low. What are you thinking for him? Yeah, so these are all good ones, especially with his age, thinking like, outside the box. Could this be malignancy? Could this be dissection? Could this be a AAA? What are you going to do with him once you get him in? Are you going to, so somebody you're getting access on? Okay. You're going to transport him like lights and sirens? You're going to take him to a closest hospital, or are you taking him to specialized care? Okay. Specialized is good. Because regardless if it's malignancy, if it's a dissection, if it's a AAA, he's also hypotensive. He also has, this is also, you can't rule these things out, like the epidural abscess, you can't rule out AAA, so he needs to go to a vascular center. You're going to prioritize like large bore IV, minimize your scene time. You don't want any unnecessary interventions. I know this guy's hypotensive, maybe give him a touch of fluid like 250. Don't really fluid load him. It's not somebody you're going to give like a huge bolus to. But not every patient that you're dispatched out, like you think 75-year-old guy, you're going out for back pain, that's what you dispatch on. You're like, okay, this guy probably just needs transport. He probably just, it was almost like a lift assist. And you get there, just remember that not all back pain is spine related. It could be vascular catastrophe. It could be urologic in nature. You get dispatched on this lady. She's a 65-year-old female. She has a history of breast cancer. Her pain's worse at night. She's been having some night sweats. She's getting actively treated for her breast cancer. This one's probably pretty obvious. You're probably thinking that she's got some spinal mets, some bone pain. For her, you're going to think about, like, does she have a pathologic compression fracture? Does she have spinal mets? You're going to try to help her with her pain. Just realize that she might have other pain meds on board, so I would always ask a history like, hey, what have you taken today for pain? When was it last? Assess their breathing status. Are they altered? Are they with you? Before you really give anything else. Most common types of cancer that are going to metastasize to the spine are bone, liver, and lung cancer. And then the night pain is always kind of a telltale sign. This is the guy you get called on. He's a 52-year-old guy. He's had some low back pain. He started not being able to urinate. That's new. And he has some saddle anesthesia when he's wiping going to the bathroom. What are you thinking? Okay. Are you running lights and sirens with this guy? Okay. If you're thinking cauda equina, how long do we typically have for these patients to do their surgery? So the chances of him being a 52-year-old guy unable to urinate, the chances of him calling EMS, he's probably already within 24 hours of all this starting. He probably is not calling you abruptly like, oh, I haven't peed in 8 hours. So I would probably run lights and sirens with him just because you want to get that 48-hour mark. That's like the golden time frame for intervention. You can also think epidural abscess or maybe a tumor that's compressing his cauda equina nerve. But nonetheless, they're still going to go in and decompress them as best they can. If you think about how long it's going to take for that patient to get in, get CT imaging at a local rural ER, for the radiologist to read it, to get accepted for a transfer, to go to a bigger center, and you're already 24 hours in, you're cutting his time, I would also ask these patients, like if you're thinking that they're, one of the 6, emergent types of back pain that we talked about, if you're thinking that, I would also ask them when they eat last. Don't give them anything to eat. They may show up and have emergent surgery, so we don't want to, obscure that in any way. Obviously, they're still going to get the intervention, but we want to make sure that we minimize their anesthesia risks as much as possible. Okay, this is multiple choice. So 58-year-old guy complains of upper back pain that began while he's mowing his lawn. He says it felt like someone ripped him apart. He's got BP differences in his arms greater than 20 millimeters of mercury, which is the definition. His heart rate's normal. He's breathing fine. He didn't have any chest pain. What are you thinking this guy's got? Okay, why don't you think he has ACS? So I think a good point is we don't always have to have chest pain for ACS. We could just have... Yeah, you definitely are. You're really not going to, like we said earlier, you're not going to change a lot of your management on how you're going to manage this. If you think it's a STEMI, an NSTEMI, or if you think this guy has a dissection, I don't think it's wrong to load him with aspirin if you don't know on the scene and you're seeing those EKG changes and you think it's a STEMI.
For those online, the question was, if the guy having a STEMI has neurological symptoms, you got your diagnosis. What's going on? If they're having a STEMI and a stroke at the same time, unless they're an Alabama graduate, what's going on with them? That's a dissection, right? Yeah, but so you got something dissecting back to the coronary arteries and going up to the vertebral or carotid. So STEMI stroke at the same time, which system do you put them in? Where do you go? You want to go to the place that has a cath lab, because that cath lab is also going to have a vascular surgeon, because they got to have it for their backup. That's what needs to happen to that patient. So, hey, just don't do your other questions, because I'm going to be bad and cheat and use those for our YouTube so people get credit for that. So don't show any more questions, or we have to make more for that.
Okay.
So.
I don't have the answer, so there's just
Keep going quickly. Keep going. Keep going. Keep going. Keep going. Keep going. There you go.
So like I said earlier, it's gonna be easy. You're gonna remember 6 emergencies. You're gonna remember 6 red flag questions to ask them. So for your back pain, you're gonna want to remember the AAA. You're gonna want to remember the dissection, the cauda equina, epidural abscess, osteomyelitis, and malignancy. So I think about these like there's 2 vascular disasters I got to remember. 1 musculoskeletal, 2 infectious, and then 1 cancer. So if you group them like that, it's kind of easy to remember about organ system. 6 questions you're going to want to ask. Have you had any fever when this has been going on? Sometimes fever is the first thing that they have. Do they have active cancer? Have they used IV drugs recently or ever? Do they have weakness? Any saddle anesthesia? Urinary retention? Oftentimes urinary retention, it might be the only symptom that they have. They might just say, yeah, I just haven't been able to pee for a little while. You might think they're dehydrated. You might think, wow, like this might just not be anything. Maybe they forgot, who's going to remember how many times they peed in a day. So that's always important to remember. If they have that might just be like a telltale sign. I always like to go off vital signs. So you get this patient, you think the 22-year-old, right? He's going to tell you he has 10 out of 10 back pain. He's never been to the doctor before, but he doesn't have a high heart rate. His blood pressure's fine. He's not breathing fast. He's just groaning in pain, complaining. That's going to tell me this might be a 10 out of 10 for him, but to me, he's not tachycardic. His blood pressure's not up. He's not breathing fast. I'm thinking, okay, maybe it's a little less, serious. Not to dismiss his pain, but just remember that being objective, using your brain, using your training to assess the vital sign is going to tell you a little bit more about how the patient's feeling with their pain, just like for a dissection and things like that. It's going to be important for you to constantly reassess the patient, and that can help you tell, hey, you're getting more tachycardic, your blood pressure's going up, maybe we should redose your pain medicine. Does anybody have any questions?
All right, I got one just for Dr. Ferguson's benefit.
Okay.
So which of these non-traumatic causes of back pain should we use full spinal immobilization on, backboard and CID and a neck C-collar?
None.
Yes.
Okay. Yeah. Remember, state says that blunt trauma and obvious signs of paralysis, you stay on a backboard. Otherwise, you don't. Now, if the patient is huge, or they're crashing on you, you don't have time to roll them en route to the hospital, that's one thing. But backboards do nothing to immobilize the spine. So, yeah. So great lecture. It's great to hear things that aren't, like cardiac arrest, because we run a lot of the calls like this, and it's good to kind of risk stratify them. Y'all have heard us talk about the reason we get a history on somebody is to determine how fast we do the things we have to do and how to move. So the history questions we can ask, their exam findings, back pain, most of it is non-emergent. But if you get caught in that lull, think it was all non-emergent, you're going to miss things and feel bad about somebody dying. I would say if you think your patient that with back pain has a cauda equina, when you get to the hospital, say that. Somebody's going to roll their eyes at you. That's okay. It's like marriage. You can take it. It's all right. You know what I'm saying? If you think you have an aortic dissection, say those words, say the catchphrases. That's going to make that triage nurse or that doctor stand up and come talk to you and talk to your patient. Because it looks pretty bad when EMS brings a patient in and tells me, hey, I think this guy's got a dissection. And I'm like, nah, we're fine. And 40 minutes later, lo and behold, he has one. It's not a good look, right? So say those catchphrases. Folks will make eye contact and think you're weird sometimes, but that's okay. Red flags for back pain, great. Anything that has systemic symptoms along with back pain should make you concerned. Unstable vital signs, fever, bad history, things like that. I think one of the things in the future that I think is going to help EMS as a whole, by EMS, I mean the EMS system, the first responders, the transporting unit, and the ER staff, is going to be in the future, maybe we have a way that we have one point of contact for EMS med direction. So if you're on scene and you got this patient with X, Y, and Z, you can call and get a doc that you know from your local area that understands you and the protocols, and you can make the decision of where do you go. Do you go to the hospital that's closest to you, which you normally go to, or do you bypass one or two to get to that place that does have that CV surgeon or that neurosurgeon? You can't do that with all your patients because you'll overload the system. You'll be out of your network for a while. But with the technology we have today, with communication, with HIPAA compliant FaceTime things, we can make those decisions real time and really improve the system and patient care too. So hopefully we're going that direction in the near future.
Sure. So we've got limited diagnostic tools in a pre-hospital setting. At what point or what clinical finding would the heart rate and targeted blood pressure treatments for dissecting the aorta, is there a trigger there?
Yes.
Indication for that without imaging?
I'm not expecting this to be a pre-hospital treatment plan. This is typically what we're initiating in the ER because we're typically getting like an arterial line so that we can closely monitor their blood pressure and make sure that we're titrating the medications appropriately. I think the only times that you guys would see it in the pre-hospital setting is if you're transporting a patient that has a known dissection or a known AAA and we're trying to keep them under that 120 systolic goal. I definitely think the most important for you is probably knowing not to really fluid overload these people. If they're hypotensive and you have, that STEMI stroke appearing patient and you're like, wow, they're a little bit, like 100 systolic or they're kind of getting soft. You want to make sure you're not like giving them a huge, 1 liter bolus. But I don't know about you, Ferg, but I'm not expecting this to be a pre-hospital treatment.
No, it's just like strokes, right? So ischemic versus hemorrhagic, the treatment's a little bit different as far as blood pressure management, but you don't know that you have ischemic or hemorrhagic till you get that CT image. Same thing with the dissections. You got to have that diagnosis confirmed before you treat it because it's not a common event, and if you treat it and you're wrong, you'll kill somebody if you treat the wrong thing, if that makes sense. So you got to have that diagnostics, or if you're doing inter-facility and you're a critical care going from point A to point B, and the diagnosis is aortic dissection, heck yeah, you're going to do heart rate control, blood pressure control. You got to weigh the risk to benefit of volume restoration if there's a leak with that. But if you don't have that definitive diagnosis, just like with strokes, you can't treat it yet.
So follow up that additional question is nitroglycerin contraindicated for any reason for patients who suspect of having aneurysm or dissecting aorta?
If they have a diagnosis of aortic aneurysm, there's no reason to give them nitro, and that's the only tool that you have to control the blood pressure. And if that's the only tool that you have, you should be critical care, and it should be IV nitro that you can titrate. And that's still not the right drug. But there may come a day when there's a shortage of everything else. I don't know. Sublingual nitro is not indicated in aortic dissection, things of that nature. And remember, nitro, there's risk and benefits to it, right? If you're given sublingual, that's actually a pretty big dose. You're going to make sure that the vital signs remember that parameter. They shouldn't be bradycardic, shouldn't be tachycardic. You got to have IV access and fluids. So,
yeah, I think this is in the context of the patient complains of chest pain, but also has a aneurysm.
Yeah, so I think I'm doing probably fentanyl, morphine, things of that nature with that chest pain. And if I know they have a dissection, then I'm doing something else critical care wise to lower the blood pressure and not using nitro because it's.
Yeah, we're using nitro and ACS for the vasodilation. I keep hearing people referring to it as an analgesic. To me,
it's really not.
It's not an analgesic.
Yeah, and the trend now, most places, we're not using a lot of sublingual or topical nitro and ACS. We're doing antiplatelets. We're going to the cath lab or using lytics. We're doing IV analgesics like fentanyl and morphine, things of that nature. And if I'm using nitro, it's most of the time going to be IV nitro. The biggest need for nitro, in my opinion, in the pre-hospital setting is for pulmonary edema, volume overload. The person whose blood pressure is 200 over 100 or better, they're sitting upright, gurgling, hypoxic, they need CPAP, BiPAP, they need nitro. There's not much
early and often.
Early and often, but otherwise not a big need in my opinion. There are better things out there.
All right, very good. Great lecture. Thanks, Dr. Pittman. Thanks to both the physicians today. Hey, Dr. Ferguson, where we headed to next time?
So I think we're in Fultondale the second week of August, and then we're in Tuscaloosa. I don't remember September. All the dates through January and locations are posted on the website now. My goal is to have topics and speakers posted at some point in August for the whole year, so you know where we're going. And don't forget, we are doing the prelim round for the sim competition for the state, for trophies, bragging rights, and next year's admission free. And we'll put up, before August, I will have the scoring sheets that we're going to use for the sim. If you go to the state website now for the state conference, there are 2 categories you can register for, and it's going to be the field EMS, which will be an EMT and a medic crew, and then there's a critical care, which could be 2 critical care medics or a flight nurse and a flight medic. But there are 2 categories to go through. We'll put the scoring sheets up online, hopefully here in the next few weeks as well. So, Cadaver Lab, September 24th and 5th, I believe. It'd be the afternoon of the 24th and the daytime of the 25th in Birmingham. It's free. That'll be on Eventbrite in the next few weeks, but it's the afternoon of that Thursday, and then from like 9 to 3 on that Friday. We can do chest decompression, IOs, maybe some surgical airways, things of that nature as well. So if you're in the Birmingham area, come do those. I can't travel with dead bodies, but I can offer the class free in Birmingham.
Oh, thank God. I thought you were about to say something different.
Yeah.
Yep. Thanks to the docs. Thanks for everybody participating. Thanks again for everybody tuning in, and we'll see you next time.